Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to your 250. Which of the following is the most likely diagnosis for this patient's condition? So this question is straightforward, asking us about the diagnosis in this patient. So let's see, a 32-year-old woman who presents with a several month history of bloody diarrhea, abdominal cramps, and unintentional weight loss. She describes up to 10 episodes of diarrhea per day. Physical examination reveals diffuse abdominal tenderness, and there is no palpable mass or perianal disease. Lab tests show macrocytic anemia and an elevated erythrocyte sedimentation rate. Colonoscopy reveals continuous areas of erythema, friability, and pseudopolyps in the colon. Biopsy of the affected mucosa shows cleft abscess and a chronic inflammatory infiltrate. Which of the following is the most likely diagnosis of this patient's condition? Irritable bowel syndrome, Crohn's disease, diverticulosis, ulcerative colitis, and celiac disease. So we can see the patient is having bloody diarrhea. From the video of Crohn's disease, you know that whenever colon is involved, then the patient will suffer from bloody diarrhea. In case of Crohn's disease, colon is rarely involved, so the patient is having non-bloody diarrhea. But in case of ulcerative colitis, the pathology starts from the rectum most commonly and it extends towards the colon. So the patient is having bloody diarrhea. The patient will having abdominal cramps and unintentional weight loss. And here we can see that the patient is having macrocytic anemia and an elevated erythrocyte sedimentation rate. Macrocytic anemia is because of the blood loss or the hemorrhage through the bloody diarrhea. The colonoscopy reveals continuous areas of erythema, friability, and pseudopolyps in the colon. We know from the Crohn's disease video that in Crohn's disease, the patient is having skip lesions, but in case of ulcerative colitis, the patient will be having continuous lesions. That there will be no gap between the two lesions. The lesions will be continuous. And pseudopolyp is one of the complications of the ulcerative colitis. And also the biopsy of the affected mucosa shows crypt abscess and a chronic inflammatory infiltrate, which is typical for the ulcerative colitis. Now let's also discuss whatever I have said in this text format. So the patient most likely diagnosis for this patient's condition is ulcerative colitis. Key findings include chronic diarrhea and bloody stools. The patients present with a several month history of chronic diarrhea, bloody stools, abdominal cramps, and unintentional weight loss. These symptoms are indicative of inflammatory bowel disease. Abdominal tenderness, physical examination reveals diffuse abdominal tenderness, which is often seen in patients with UC due to the inflammation of the colon. Macrocytic anemia suggests chronic blood loss, which is common in UC as a result of rectal bleeding. Elevated ESR, elevated ESR is a marker of inflammation and it is often elevated in patients with ulcerative colitis. Colonoscopy findings reveals continuous areas of erythema, friability, and pseudopolyps in the colon, which are typical endoscopic findings in ulcerative colitis. The disease typically starts in the rectum and extends proximally in the continuous fashion. Biopsy findings, a biopsy of the affected mucosa shows crypt abscess and a chronic inflammatory infiltrate, which is a histological hallmark of ulcerative colitis. Now, in this video, we will typically discuss about the differences between the ulcerative colitis and the Crohn's disease in detail. So, let's dive deep into it. Ulcerative colitis is the most common inflammatory bowel disease, more common in whites than blacks, whereas Crohn's disease is more common in whites than blacks, and there is no sex predilection in both of these conditions. The ulcerative colitis generally occurs between the ages of 15 and 40 years and 50 and 80 years. So it has a bimodal distribution of the age, but in case of Crohn's disease, the disease generally occurs in case of third and fifth decade of the life. Now, we can see that ulcerative colitis generally occurs early in life than that of Crohn's disease. There is lower incidence in current smokers and other nicotine users, but there is increased risk of ulcerative colitis in case of ex-smokers. There is lower incidence if the previous patient had appendectomy prior to less than 20 years of age. The infection with non-typhoid strains of Salmonella or Campylobacter jejuni associated with greater risk in the following year. Increased risk if the patient has autoimmune disease. Now you can see that if the patient has autoimmune disease, he will be at increased risk of many of the diseases from his early year of life. Also, one of that is ulcerative colitis. The patient may suffer from UC in about 15 years of his life. Extent mucosal and submucosal, and Crohn's disease is the extent of the injury is transmural. So this is a very important difference between the ulcerative colitis and the Crohn's disease. Is that in UC, only the mucosa and some mucosa is involved. But in case of Crohn's disease, all the layers of the GI tract is involved. Location, mainly rectum, usually begins in this location and extends in continuity into the left colon. May involve the entire colon too sometimes, which is called as pancolitis. It does not involve the other areas of the GI tract, whereas the Crohn's disease generally starts in the terminal ileum in 30% of the cases, and colon in 50% of the cases, and it involves the other areas of the GI tract from mouth to anus. It can happen anywhere. Gross features, there is ulceration and hemorrhage, inflammatory pseudopolyps. But in case of Crohn's disease, there is thick bowel wall and narrow lumen, which leads to the obstruction. And one of the complications of Crohn's disease, therefore, is small bowel obstruction, which is the indication of surgery for Crohn's disease. Aphthous ulcers in bowel may be an early sign. There may be skip lesions, strictures, fistulas, and bowel lesions. There may be deep linear ulcers with cobblestone pattern, and pseudopolyps are present sometimes. There is fat creeping around the serosa, which is a very important gross finding in case of Crohn's disease, and maybe the only feature sometimes in the diagnosis of Crohn's disease. Macroscopic features, the ulcers and crypt abscess contain neutrophils, and there is dysplasia or cancer. But in case of Crohn's disease, there is non-caseating granulomas, lymphoid aggregates, and the dysplasia cancer are very less likely in case of Crohn's disease. The clinical findings is that the recurrent left-sided abdominal cramping with bloody diarrhea and mucus, abdominal pain is not severe. There is severe recurrent right lower quadrant colicky pain due to obstruction with non-bloody diarrhea. So there is left-sided pain in case of ulcerative colitis and right-sided pain in case of Crohn's disease. There is fever, tenesmus, or weight loss. Proctitis, because there is involvement of the rectum. Toxic megacolon, which is in 10% of the patient, but toxic megacolon may also be present in 1% of the patient of Crohn's disease. The mortality rate is 50%. There is no fistulas, whereas there will be fistulas in case of Crohn's disease. There are some extra gastrointestinal findings like primary sclerosing cholangitis, primary biliary cirrhosis, pyoderma gangrenosum, and HLA-B27 positive arthritis. Because you know that these all conditions are again autoimmune conditions, and UC may be also sometimes autoimmune. There may be extra gastrointestinal findings in case of Crohn's disease, which may include sacroiliitis, primary sclerosing cholangitis, P-NK positive antibodies may be there. There is elevated C-reactive protein and ESR and thrombocytosis in case of ulcerative colitis. Also, there may be elevated CSR and elevated ESR and CRP in case of Crohn's disease too. The radiography is where the real difference is seen. There is lead pipe or tubular appearance in the chronic disease in case of ulcerative colitis. So the tubular appearance results from the loss of rostral force in the colon. The string sign in the terminal ileum from luminal narrowing by inflammation or fistulas is present in case of Crohn's disease. Talking about the complications of the Crohn's and ulcerative colitis, the complications part is generally tested in your USMLE examination. So please remember these complications. The patients of ulcerative colitis are at increased risk of having toxic megacolon, adenocarcinoma, but the patients of Crohn's disease will be at increased risk of having anal fistulas, obstruction, calcium oxalate or renal calculi. These are due to the increased reabsorption of oxalate through the inflamed mucosa. The patient will be having malabsorption caused by the bile salt deficiency, and the patient will be having vitamin B12 deficiency if the terminal ileum is totally involved. Here you can see in case of ulcerative colitis, the colon shows marked ulceration and pseudopolyposis. Here you can see these small are the pseudopolyps, which account for the irregularity of the internal intestinal surface. Or in the endoscopic biopsy of the ulcerative colitis, you can see there is marked inflammation, crypt distortion, and crypt abscess. So this one is the crypt abscess. Also, you can see that there is the pyoderma gangrenosum, which are the multiple deep necrotic ulcers with dusky overhanging margins. which are characteristic of pyoderma gangrenosum. In case of Crohn's disease, the disease is localized in the terminal ileum and the right side of the colon, but it may extend and lead to adhesions, fistula, perianal abscess, peritonitis, and it may be combined with a cecum, which is called as a combined disease. You can see that the crisscrossing ulcerations producing a convolutional appearance in case of Crohn's disease in this radiograph. Also, now let's talk about the extra-intestinal manifestation of the inflammatory bowel diseases. So the complications may occur during the active phase of the inflammatory bowel disease, which may include conjunctivitis, iritis, episcleritis. Now you can see that the many of the conditions in this figure are autoimmune conditions. So the autoimmune disease play a very important role in the pathogenesis of the inflammatory bowel disease. So in case of active disease of the IBD, you can see that other autoimmune conditions in other systems may also flare up. So during the active phase of the disease, the patient will be having conjunctivitis, iritis, episcleritis, mouth ulcers, fatty liver, liver abscess, portal vein thrombosis, venous thrombosis, large weight arthritis, erythema nodosum, or pyoderma gangrenosum. And there are some of the complications which are unrelated to the inflammatory bowel disease activity. Even if the disease is in the passive phase, there may be some other complications like autoimmune hepatitis, primary sclerosing cholangitis, gallstones, amyloidosis, and oxalate calculi, sacroiliitis, and ankylosing spondylitis, and metabolic bone disease. Summarizing all the extra-intestinal manifestation in this slide is given. The extra ones here are the idiopathic thrombocytopenic purpura, osteoporosis, and sclerosing cholangitis in ulcerative colitis sort of patients. Thank you for watching. Keep studying hard.